Hi everyone, I'm Elizabeth Wells at Children's National Hospital, and I'm going to talk about the pediatric patient with acute weakness, when to think about AFM. So as clinicians and researchers, we know that timing is key for AFM. And today, in this part of the afternoon, we're going to focus on how to recognize AFM early. We need to be alert for the onset of acute flaccid limb weakness and consider AFM on our differential diagnosis. So let's meet Antonio. He's a 6-year-old boy that's presenting to the emergency department. On day 1 of his illness, he had a fever, some upper respiratory symptoms, and on day 2, he had a diffuse erythematous rash. Pretty typical. Then 2 days later, he was playing with his brother and he abruptly stopped using his left arm. The family tried to troubleshoot, called the pediatrician, who referred him to the emergency department. The past medical and social history revealed that he was a 6-year-old child with normal development, no medications, allergies, or surgical history, lives with his parents, 4-year-old brother, and maternal grandparents in Maryland, all doing well. 2 healthy dogs, no travel or known insect exposures, and his immunizations were up to date. There was no family history of autoimmune disease. Physical exam, he was afebrile, and his general exam was unremarkable except for the fading papular rash on his trunk. However, his neurological exam was notable for having occasional head drop, a left arm that was limp hanging on his side with decreased tone, and efforts to get him to reach for toys were unsuccessful. He was also found to have decreased muscle tone, diminished deep tendon reflexes, in particular of the left brachioradialis, the biceps, and the triceps. Lab and diagnostic testing showed that a left shoulder x-ray was fine. A head CT was negative for acute findings. His blood work was generally unrevealing for any elevated inflammatory markers. However, his CSF had a significant pleocytosis with 84 white blood cells and mildly elevated protein. And this was his spinal cord MRI. So that showed the abnormality of the T2 hyperintense signal with some enhancement that was largely restricted to the gray matter and spanned C3 through C6. So there was, of course, some additional workup done, but ultimately he met the criteria by the CDC for having a classic case definition of acute onset flaccid limb weakness, confirmed AFM case where he also had the MRI findings. And so that was a classic case, but do they always present that way? I thought it might be helpful to dissect together this statement, the presentation of a pediatric patient with acute weakness. So to start, the patient. The patient is usually a young child. The median age is 6.3 years. However, there can be quite a range. It's generally male equal to female. Some studies have shown more male predominance. And all races and ethnicities may be affected. The child is usually previously healthy, but certainly is not a child that has had prior demyelinating events or other significant neurologic conditions of the spine. The second component of our pediatric patient with acute weakness is acute. So what do we mean by acute? So most patients with AFM do have rapid progressive weakness. However, some have more of a stuttering start or a prolonged plateau rather than a fulminant onset, and this tends to be the more mild cases. So for that reason, we consider it to be at hours to days, and actually up to 10 days is what the AFM working group and others have felt is appropriate to include in terms of the presentation because of those more mild cases. So the third component is the weakness. And here I want to spend a little bit of time. There are certain features of it that can help us to differentiate AFM from other conditions. So the weakness is often asymmetric. It can involve 1 or up to 4 limbs. It's usually upper proximal muscles more than the lower distal muscles. And there can be a range in severity, anywhere from mild weakness to severe paralysis. Children also often have a weak neck, trunk, or diaphragm, and 30% have bulbar weakness. So these are the lower cranial nerve dysfunction resulting in changes in their speech. They may be speaking less, or they may have hypophonia. They may have swallowing difficulties, drooling, as we heard earlier today about Braden. And they may or may not have weakness of the eyes, face, or neck. So on neurologic exam, and here are some pictures of some of our patients who've actually asked us to include them in presentations if it may help other children. On neurologic exam, you look for the proximal muscle weakness. And ways that when we're having a conversation with the emergency department or pediatricians, we're asking, what happens when the child attempts to raise their hands over their head? Can you get the child to go from sitting, legs crisscrossed, to standing up from the ground? And then we kind of dig further into, is there axial weakness present? So here you're looking at neck flexion and extension. Is there decreased muscle tone, deep tendon reflexes in the weak limb? Of note, the reflexes may actually be fine at the beginning, sometimes even hyperreflexic. So the presence of reflex, of deep tendon reflexes, does not by any means rule out AFM. And then we want to pay close attention, as I said, to the cranial nerves. This is a nice poster that the CDC has made going through the symptoms of AFM and linking it to the nervous system. So how to spot symptoms of AFM in your child. They talk about difficulty moving the eyes or drooping eyelids, the facial droop, the difficulty with swallowing or slurred speech, and the sudden arm or leg weakness, and says seek medical care right away if your child has any of these symptoms. So any one of these should be a reason to seek emergent medical attention. And this is important because many parents don't usually think of the nervous system or the spinal cord when their child's arm is hurt. We all know that many of them are thinking about orthopedic injury or trauma. And in fact, it's often after a mild injury that we discover the problems associated with AFM, simply because children are active and minor injuries are common. So associated symptoms can also give you a clue. Cases of AFM often, but not always, present with a prodromal fever and respiratory symptoms. We're going to hear a lot more about this, as we already have from our ID colleagues. And the symptoms, however, the fever usually resolves before the weakness, and it's not necessary for the diagnosis. Less frequently, we see GI symptoms, and sometimes we see a headache, stiff neck, or return of the fever at the time of the weakness. There may also be pain in the affected limb, the lower back, or the neck. There can be bowel or bladder dysfunction. Many of the children have constipation. There can be autonomic manifestations. And even at presentation, sometimes you can find these problems with the labile blood pressure, irregular heart rate, and breathing patterns. What's not typical are sensory change. So other than the pain, it's not common to see absence of feeling in a limb. It's also not common to have encephalopathy, tiredness, fatigue, confusion, obviously because it's the spinal cord that's affected more than and not the brain. And we don't see seizures in these patients. And so there's a pretty broad differential diagnosis and a number of conditions that AFM can mimic. We found it helpful to consider different features that may differentiate these conditions. And here I've just listed some of the ones that we think about a lot, which are poliomyelitis, other demyelinating transverse myelitis, so like NMO, MOG, or MS, and I think we're going to hear more about that from other speakers, Guillain-Barré, and stroke. And what's especially helpful with AFM is, again, remembering the symptom onset tends to be over hours to days, and the weakness usually being one limb, but again, it can be multiple. And again, the asymmetric component and upper more than lower, although it certainly can be lower too. There are other conditions to think about as well, like the acute disseminated encephalomyelitis, botulism, tick paralysis, and those all have other features too. So what are some of the strategies that we do to make sure that everyone who sees a child or hears about a child with these symptoms may think about AFM and that it comes to mind, even though it's a rare condition. So we're all working to educate the frontline providers, parents, and community. We found it particularly helpful to have institutional pathways and protocols at our hospital. So in this pathway, we include a typical clinical scenario as well as other presenting signs, standardized workup, and we recommend evaluation and treatment, but to always consult neurology and infectious disease. And at our hospital, it's usually the neurology fellows that are called first because the emergency department calls us, for limb weakness. And we emphasized to our team that this is a neurologic emergency. We need to think about it like we think about stroke and other brain attacks. And then we include, current references in our pathways to help. We also have an EHR order set specifically for AFM so that it's not challenging to order the particular diagnostics that we want. I work very closely with Dr. Roberta DiBiase and our whole AFM team to make sure that we're aligned and that our order set is up to date, and we update that annually. And so we find that these are some strategies that have helped. So in conclusion, we should strongly consider AFM in a pediatric patient with rapid onset weakness, especially after respiratory illness or fever, especially in August through October, but at other times as well. Our hope is that early recognition will lead to prompt reporting and investigation, appropriate specimen collection for clinical purposes as well as for research, and ultimately the best care. I just want to acknowledge what a pleasure and privilege it's been to work with the AFM working group under Dr. Pardo. Here's our AFM task force at Children's National, and it's a combined effort between multiple disciplines, and of course to thank our patients and families. And now I think I am going to introduce Dr. Hopkins, who's going to talk about how to diagnose AFM and what to do in the emergency department. Thank you, Sarah.